Good afternoon, everybody. Good afternoon, everybody. Today I'm going to tell you about an eyelid itch which turned costly. So there is a 57-year-old female who presents with a complaint of itching in the right upper eyelid for since 6 months. It was associated with mild redness and loss of lash, but there was no history of any allergies. She was diagnosed and managed outside as recurrent blepharitis since a long time, but there was no resolution in any symptoms. When the patient presented to us, there was loss of lash in the right eye with erythematous skin around the lashes. There was also a mild distortion of the lid margin which was present, along with a mild thickening, and on inversion, we could see congested palpebral conjunctiva. So at this point, our differentials were either a chronic blepharitis, which is refractory to treatment because of the itching and erythema which is present, or it could also have been a more sinister presentation. There is a sebaceous cell carcinoma due to the age group of presentation and the location on the upper lid. Plus, there was also a distortion of the lid margin. So we went ahead and did a biopsy, and surprisingly, we found numerous epithelioid cells and Langerhans giant cells, suggestive of a non-cageating granulomatous inflammation. So now our differentials became tuberculosis, sarcoidosis, Wegener's granulomatosis, or a fungal infection. But asking the history, there was no history of any rhinorrhea or hemoptysis, and no necrosis found on the histopathology, so we thought that Wegener's was less likely. Plus, in an immunocompetent person with a fungal stain negative on histopathology, fungal infection was also deemed unlikely. Yet we did a whole battery of systemic investigations for the patient, but only abnormal values were the ESR, which was raised, the chest X-ray, which showed bilateral asymmetrical hilar lymphadenopathy, and the Montauk's test, which was positive. So seeing this along with the normal serum calcium and serum ACE levels, our first suspicion was the tuberculosis, because as we know in India, everything is TB unless proven otherwise. So we did a repeat biopsy for the TB gene expert, but that was also negative. So now we were utterly confused, and we asked the pulmonology department for our last hope. So they asked the history of the patient again, and there was some dyspnea on exertion. So they did a pulmonary function test, which showed a mild restrictive lung disease. So now we were getting somewhere. We got an HRCT chest done, where it showed ground glass opacities with bilateral micronodules and a thickened septa. So further on, to confirm these findings, we got a biopsy from the mediastinal lymph nodes, which showed non-caseating granulomatous inflammation. Hence, a diagnosis of sarcoidosis was made. The patient was started by the pulmonologist on tablet prednisolone 1 mg per kg per day, which was tapered by 10 milligrams per week. And on 1 month, we found that there was no itch at all. There was decrease in redness, decrease in the lid swelling, even few lashes had regrown, and the pulmonary function tests had improved. And this magical response to steroid also supported our diagnosis of sarcoidosis. Sarcoidosis, as we know, is a chronic, non-cageating granulomatous multisystem inflammatory disease, while ocular involvement is only seen in 20 to 30%, most commonly being uveitis. However, sarcoidosis of the eyelid is a rare entity, which may include the specific millet seed-like nodules, ulcerative nodules changes. There is no single gold standard test for diagnosis of this disease, but the American Thoracic Society says that any compatible clinical radiological finding with the histological evidence of a non-necrotizing granuloma, and after ruling out other granulomatous causes like we did in our case, we can reach to the diagnosis. For the treatment, we usually start with systemic, topical, or intralesional corticosteroids, and in resistant cases, immunosuppressant therapies have also been tried. After the active inflammation has been resolved, we can go ahead with surgical reconstruction if there is any cross distortion. So my take-home messages from this would be, first of all, never ignore even a simple history of itching inside a patient. Second, an eye can tell us a deeper story about the body, and that is our duty to reveal for the patient. And third, sarcoid can never stop amazing us, be it as an MBBS student or even as a postgraduate. Thank you so much for listening. It was indeed a costly itch.
For the postgraduates, this is exactly the way these cases are managed, exactly in the same way, whether isn't it? And role of pulmonologist, because they can take the biopsies, and that clinches the final diagnosis. Thank you very much. Thank you.
So I think the take-home message would be that any of these patients, you should not, if it's a chronic blepharitis not responding, you must try and make a definitive diagnosis and take biopsies. So this is one point which you have really highlighted well. And the other thing is, I'm a little surprised that the first instance, why didn't you get in, your HRCT did not pick up those findings in the first instance itself? Why was the confusion?
X-ray done only.
Yeah, so another take-home message is that X-ray chest again is not, it's just a screening tool lots of these findings may be missed by an X-ray
was
chest.
positive, so they did X-ray chest only.
Yeah.
And later on, she
And
subjected to CT scan. That is
sarcoidosis
how-
usually don't have a strong mount, you know, the Montus being maybe again, these are all not very reliable, you know, investigations. You have to corroborate each and everything, and whenever in doubt, always go for an HRCT, not X-ray. Yeah. Thank you.